Welcome to State of Reform's virtual leadership series with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Andy Keller is the CEO of Meadows Mental Health Policy Institute based in Texas. He's got a PhD and has been working on issues related to mental health and substance abuse at a lot of levels for a few decades now. I knew of him in particular in his old world where he was solving some of the thorniest problems. And now he's addressing some of the trickiest questions in Texas healthcare and national mental health care as well. And Susan Mims is the interim CEO of the Dogwood Health Trust in North Carolina. She's a pediatrician by training and now serving in a capacity where she can bring that experience in integrative care, integrative physical and behavioral health care to a community position, leading the Dogwood Health Trust with about $1.6 billion in endowment. So thank you guys for being with us. I appreciate it. Tom, let me ask you, just to start us off, how do you think we're doing as a community, as a national community, American community, California? How are we doing as individuals? It's been a heck of a year. How are we holding up mentally and socially?
DJ, it's actually, thanks for having me, first of all. I'm delighted to be part of this, and it'd be great to have this conversation with Andy and Susan. I think it's sometimes difficult to tell how we're doing because people are not together in the way that we normally are. We don't have great sources of data. The data that we can look at says that there are certainly higher levels of anxiety and depression, huge concern about the number of overdose deaths, which CDC reports at now surpassing 80,000. Suicide rate actually seems to be a little lower. But the key seems to be right now that we're feeling the impact of having a system that was broken even before the pandemic. I love that comment by Amanda Gorman at the inauguration, the young poet laureate who said, as a nation, we're not broken, we're unfinished. And maybe that's the way to think about the mental health care system. I think most consumers will experience it as broken, many providers as well, and certainly the payers would say that. But it's unfinished, and we have a lot of work to do. And I think what's happened with the pandemic is it's revealed how much needs to be done still, how much work there is to actually build a system that meets the needs of patients and of families, and that has the kind of integration that Susan will talk about and the kind of quality that Andy will talk about.
Andy, do you want to sort of jump in from there and maybe offer your 2 cents on where you think we are as an American community? I know you spent a lot of time in the data at Meadows, but qualitatively, how does it feel as we are in January of 2021?
Yeah, well, I like that term broken, and I love that term unfinished. That was so moving yesterday, and it really does capture things, Tom. But, to me, the reason I think people describe this as broken is because that's how it feels. It's like I have a loved one with cancer. I know how to get help. I mean, not everybody has access, but I think there are people who can help us get access. We can talk about it in our faith community. But if we have a loved one struggling with suicide, we feel alone. And when we call 911 for medical help, we have a police officer come. So what I would, though, say is it's really not so much broken or unfinished as it is misdesigned. And I think that we've designed our mental health and addiction systems on a fundamental inequity, a fundamental bias that says that we can't help people with their brains in the same way we can help them with the rest of their bodies, and we need to send them somewhere else, which of course intersects with deeper inequities across our whole health system, so related to race and income. So I think, to me, we've designed this in a way that makes it very hard for people with mental illness to receive care before years and years after their symptoms emerge. And then we make it even harder for people in marginalized communities to access any of that care and disproportionately involve them in our justice system. So I think it's misdesigned on a fundamental set of inequities.
So Susan, you, as I mentioned, you are a pediatrician by training. You've been a hospital administrator and been involved in a range of efforts as a physician leader and otherwise, and now you're at Dogwood Health Trust. How do you think your community in North Carolina, in Asheville area in particular, but North Carolina in general, how how is that community holding up under the strain of the pandemic?
Well, I will say, I think everyone is tired. I mean, we hear about that, and people are feeling isolated, and we know that this pandemic has been so hard on so many, especially people who are oftentimes not in the forefront of our thoughts when in healthcare delivery. I've also seen some really hopeful signs. I think there are some of what has come out through the pandemic are our broken systems, and they're now that light shining on them. We can't ignore it anymore. And I think because when you're in a time of crisis, we are been allowed to think creatively and actually do some things that we weren't able to do before. For whatever reason, it's the way we've always done things. There were lots of barriers, but we have used telehealth, virtual health, in a way that I think both we had resistance from providers and patients, on how we could do that. And when I see what's happened with that, it is amazing. I hope we won't go back. I hope we will continue to, we've had our rules and regulations changed to allow it to be used in a lot of ways that we didn't think were possible before, had huge barriers. We have MAT providers out, meeting people who are not housed where they are to keep their treatment, their opioid replacement treatment going so that they don't relapse. We weren't, there were barriers to that before. So I certainly see some really hopeful things that have happened out of this, the resiliency that's coming out that I really hope we can capitalize on that and help that move us forward in this breaking down the physical and the mental health worlds moving forward.
So Andy, so you've talked a little bit about some ideas and Susan notes, I think appropriately, that this is a time for creativity. In your conversations with folks in the transition team, now the Biden administration, where do you think there are some opportunities to move mental health policy forward in the next administration?
Well, I think Susan noted one of the most important ones, which is telehealth. And I think there's bipartisan support in Congress. I think the administration, I mean, at least the people I talk to, that for keeping these gains. And I think there's some subtle ones that we don't necessarily appreciate, like audio only access. I mean, we all want everyone to have access to broadband, but the reality is it's going to take a while to build that out, and there's still going to be inequities there. Many, many more people have access to telephones, and being able to have Medicare allow for psychotherapy to happen and other interventions to happen via audio. So there's some real wonky things we need to really strongly keep. And I believe there is sensitivity to that. I mean, I think the other thing, just, in terms of the administration, I think, putting Tom Coderre in as interim at SAMHSA, which happened yesterday, I think is a really great thing, because I think SAMHSA has been sort of marginalized more. I mean, back in the good old days, Tom, in 1992, before 92, it was all together. But I think it's gotten even worse under the last administration and the leadership there. And so I think that, there's a rejuvenation there, I hope, that to be able to bring that expertise in more squarely into the type of opportunities Susan talked about, as well as the challenges Tom talked about around increasing rates of overdose. And Tom, I would say too, I do think that, I think on the suicide, it's hard to tell because we're so delayed in getting our data on suicide. So, we just found out last month that in 2019, suicide rates kind of leveled off as a group. They continue to go up in some very concerning subgroups like African-American youth, and continue to increase for women. They did go down a little bit for my demographic, which is the white guys in their 50s who are a big source of mortality from suicide. But, the problem with suicide is we just don't surveil it in the same way that we do other illnesses. I can tell you, yesterday, a pretty good guess as to how many people died from COVID, but we won't know until early 2022 how many people died this month, or I'm sorry, early 2023, how many people died this month from suicide. So I hope that there's going to be some gains there. And the national response that Josh Gordon's leading along with Patrick Kennedy, I think has some really great ideas there that I do believe folks in the administration, as well as in both parties in the legislature are looking at.
So, Tom, how is suicide? How do we put our finger on supporting people who might have suicidal ideation or suicidal tendencies? How do we use some of the tools of our modern age that may not be policy related, given the lag in reporting that Andy spoke to? Where are we headed in terms of trying to be able to address suicide if we have to wait this long for policy to be informed?
Well, I'm not sure how much of it is a policy problem. And actually, going back to your earlier question, DJ, about the Biden administration and where they're going to go, yeah, it's important to remember that for the most part, mental health, kind of like education, is a state activity. It's not been led by the federal government since the 1960s, starting in 1980 with the Reagan administration. For the most part, the federal government got out of the mental health care business. They said it's up to the states, it's up to local communities. We'll help to match expenses through CMS. But if you look at the total budget, that Andy mentioned about SAMHSA, it's a tiny budget. I mean, in a state like California, we barely even notice the SAMHSA block grant. It barely shows up in our $11 billion behavioral health budget. So I think it is quite important to have leadership in the federal government that's thinking about these problems, including the issue of suicide. But it's also important to recognize that this has been largely state and local. It's not been, like in many other areas, it's not been driven by federal leadership for many, many years. That may change, by the way, with the stimulus package. SAMHSA is almost double the size that it was a month ago. There are large efforts underway to build out specific programs like the certified community behavioral health centers. And so some of this is starting to change, but it's been 40 years in the making. On this topic of suicide specifically, I think you're right, Andy, to say that we don't manage what we don't measure. And in the case of suicide, we have not been willing to measure it. And so no one's been held accountable. I think the number one thing you want to get if you're trying to change outcomes is accountability. You need to know who's in charge of actually managing this problem, who's responsible, who gets fired if the suicide rate goes up, and who gets rewarded if it goes down. I can't tell you who that is. I can't even tell you what the numbers are. I can tell you the homicide numbers and the COVID numbers and the numbers for HIV. But we are, as Andy said, 2 years behind and even monitoring suicide. So that's extraordinarily worrisome. DJ, to your specific question about how do you get ahead of this? What can we do? I think a part of it is actually doing a better job of monitoring and managing, and beginning to demand this of leadership, that this becomes recognized as an important public health issue. We're at about 48,000 suicides in the United States every year. That's far more than the number of breast cancer deaths, right? More than the number of prostate cancer deaths. It's more than double the number of homicides. So we ought to be thinking about this as a serious public health issue. The rate of suicide in the US has gone up about 33% since 1999. Important to recognize that in the rest of the world, with a few exceptions, the rate of suicide has gone dramatically down. Globally, suicide's down about 38% in that time. So the United States is really exceptional in this sense. We have managed this worse than just about any other developed country. And it is one place where I think it is reasonable to ask for a federal leadership role to say, massive source of mortality, just like COVID, we've got to do something with a national strategy that makes a difference. What is that? Part of it is going to be monitoring. Part of it is going to be early intervention and making sure that more people get treated. And then a huge part is not just prevention, but postvention. 1 in 5 suicide deaths is from somebody who has been in the emergency room for an act of self-harm in the previous 12 months. 50% of those people are never seen again until they end up in the morgue. That is really unacceptable. We can do far better.
Wow, there's a lot to unpack there, Tom. Maybe we should just do a 3-hour seminar and just listen to you talk for a little while. Susan, I'm sorry to ask you to follow up on that. And I'm specifically actually wondering about how you think these social determinants that play into mental health degradation, how we might do better as communities to think about addressing those? If people are showing up, late to the ER, if we're having a hard time tracking, if we're doing a relatively underperforming job as a community to address mental health, how do we try to address some of the social determinants that can degrade mental health so we move upstream a little bit? What are your thoughts there?
Yeah, that's a great segue for me, why I'm actually where I am now and where my career path has gone from clinical to really looking at working for a foundation that is focused on dramatically improving the health and well-being of people, and doing that not through specific health care interventions, but focusing on housing, education, jobs and economic development, as well as health and well-being, and thinking about all of those. I mean, we know that someone really can't focus on getting the care that they need and the things that they need to do until they have a safe place to sleep, a safe place to live. And so housing first is one of our big initiatives, and helping folks get access to education and have a job. All of that is tied to ultimate health. And I think helping people see those connections. Some people say, you're a health organization, a health trust. Why are you working on, workforce housing? And it's because of that link. And then thinking about how are we being able to provide the services across all of that with an equity focus, so that people are getting the supports they need. We're identifying, being able to do screenings early, think about behavioral health first aid, and teaching the population to do that. I know as a provider, while somebody may have been in the emergency room, when I think about suicide prevention work that we've done, we realize somebody may be in the doctor's office, but they may not tell them. We may not ask. We may miss these opportunities. So we have to go out to where people are and bring those services and understand what is creating the circumstances that lead to these adverse health outcomes.
So, Susan, just to stick with you for a minute, I know clearly some of the things that cause us mental health stress are structural in nature. They're not necessarily acute. They're chronic. They're with us. They might be economic insecurity, and for many people, racism is a systemic thing that they have to experience, and that undermines their health status, both physical and mental health. Give us a sense of where the conversation is in Asheville and North Carolina in general, about addressing racism as a social determinant and a public health issue there.
That is a great question. We definitely know that racism is a public health concern. We know more and more about even some people think of racism, they think of the real overt things that are very visible. There are microaggressions that happen and people of color experience every single day, that can really impact their health and even their epigenetics. So in our area, we're having conversations around really understanding that how that impacts people's health in a way that we have maybe known but not really had a deep dive into that, and thinking about how we as a community even talk about reparations and what we can do really proactively to engage people of color who've experienced this in the conversation. I think oftentimes, the people we're working with in public health, they know what to do. They know what they need. And our role is to bring resources and help further that conversation and break down barriers to help move that conversation along.
Hey, DJ, can I jump in for a moment on this? Because I think is a really important point that Susan brings up. And it's so often missed by people who are probably on this call and listening in, which is we're very focused on healthcare and how we're going to improve outcomes through healthcare. But as Susan says, you have to separate healthcare from health. They're really two very different concepts. And the WHO talks about this today. Don Berwick and others are like Michael Marmot have really been very eloquent about this, that when you look at overall outcomes in a population, healthcare represents about 10% of the variance. It's a tiny part. We spend $3.5 trillion on that part in the United States. But even if you improve healthcare massively, you're still not necessarily going to do as much as you might be able to do for overall health outcomes in other places. And the ironic thing about that, as Susan was just saying, is we actually aren't focused on those things. I call it the 3 Ps: people, place, and purpose, making sure people, that the population has access to those 3 Ps. We don't spend money on that. We don't focus on it. We don't structure our interventions around it. So the kind of thing that Susan's talking about, let's start with housing, or let's start with education, giving people a sense of purpose, or making sure they have social support. Those could ultimately have much more massive impact on health outcomes as we know them, morbidity and mortality, than that $3.5 trillion that we're plowing into the healthcare market. And yet we, especially in behavioral health, we haven't thought smartly about this.
Tom, I think that's a really good point. And I think too, there's an intersection there because I also think bad healthcare makes social determinants worse. And to give you an example of that, I think, by not identifying severe mental illness like a psychosis early and not catching it within the first, few months, weeks of symptoms, we allow people to end up in an economic place where they cannot earn. They maybe been arrested, so it's harder now to get a job. So the failure of our healthcare system to help someone with a very severe illness like a psychosis, which makes it harder to work, makes it harder to function, then sets you on a path of cascading social determinants, which are worse. So there's this interaction between the two that I think this fundamental bias in how we have designed our health system, where we put the brain on a separate track and we talk to parents about their children, family members about their children, but we don't talk to them about their children's mental health. We don't promote that in schools. We don't find it because half these disorders begin by age 14. So we add race on that, so that not only do we wait, but if my son, when they detected his mental illness 8 years after it began in high school, was Black, chances are he would be 4 times as likely to be expelled or suspended as my son would. And so then the mental illness drives a lack of education. So I think not only, I totally agree, but I think we actually make things worse with the bias we've built into our health system. So I'd argue we're actually spending money in the wrong places that are driving up adverse outcomes unintentionally.
Andy, what I find really frustrating about that is that we actually know what to do. Like we something like coordinated specialty care that we developed through the NIMH RAISE project and a bunch of other things that are out there can reliably make sure that people who are having a first episode of psychosis at age 17 will finish school, will be able to get decent medical care, will be able to progress and not have a second episode. They won't go into chronic disability. So in the same way, the new administration has said we're going to have 100 million people vaccinated in the next 100 days. Imagine this. We're going to have 100,000 people, that is the number, 100,000 young people will have a first episode of psychosis in 2021. What if we made a commitment that said that those 100,000 will never have a second episode? We know how to do that. We could do that today. We know what the interventions are, how to put them together. That's coordinated specialty care, how to make sure that people stay with them for a year or two so that people recover. You get those 3 Ps in place. You make sure that people actually get what they need, when they need it, as they want it, with shared decision making.
I appreciate you saying that, Tom. I really do think we know that to do that, we have to go out to where people are. And we have to be in the community. And you pointed out very appropriately the funding, dichotomy is all of this funding comes into where the care is, not where the people are. And North Carolina is very close. I'm hoping to engaging in an experiment on healthy opportunities with Secretary Mandy Cohen and being able to actually use Medicaid dollars to pay the not-for-profits who are out in the world addressing the social determinants, the influences on health that are not, in the healthcare, not the healthcare that's provided, that may, as Andy said, be making things worse. But actually doing those interventions with people, we have a program on paramedics where we take paramedics and give them some extra training in community resilience. And, they often are in people's homes. They're not surprised by what they see. They're there and they can prevent, someone from being back in the emergency room, or worse, being in the criminal justice system where, some of this thing happens. And so we need creative ideas and we need them to be funded. We need, to really be able to do that work. We know what we need to do. We need to be able to have a system that promotes it.
I want to make sure that we bring in some of our audience comments and questions. And just as a reminder for audience members, I see that there's a bunch of great comments. I will try to sort of sort through them based on your priorities. So even if you're not posing comments or questions, you can upvote those questions by clicking the little thumbs up icon. And that will prioritize the comments that you'd like to have integrated into the conversation. Emily, and I'm sorry, Emily, I think we've corresponded. I've seen your name and I don't know how to pronounce your last name, Emily Nachtway. She says, I'm a first-year MHA candidate at the University of Utah. Substance use disorder treatment can be expensive and not always covered for long-term residential treatment. Do you see legislative opportunity for state or federal government programs to offer more aid for this type of treatment? Andy, let me ask you to kind of take a crack at this, at least insofar as, there are 50 states plus the district, but in Texas, what are your thoughts on how the legislature or federal government might address this?
Well, there's two big things that have happened in the last few weeks on this that are huge. One is the movement. There's a restriction, a X waiver that limits the number of people that can be given buprenorphine treatment by a primary care provider. So, just listen to the logic of this. We would allow a primary care doctor to prescribe unlimited opioids, but we would only let them treat a very small number of people relatively to treat the opioid use disorder. So that was not gotten rid of, but kind of eviscerated. And it would be great if it was just gotten rid of. I actually think physicians are just as smart. And I'm not one. I'm not a real doctor. I'm a PhD. I'm a psychologist. So Tom, I think your people, Susan, the physicians are smart enough to be able to decide how to provide treatment for opioid use disorders as well as for pain. So that was a huge one. And that just, we were just under leveraging all the folks, made an extra barrier for a physician to be able to treat. And so just getting rid of that was great, or not really getting rid of it, but like creating a loophole that allows physicians to not have to worry about that, at least for now. Second thing was there's a huge increase in funding for substance use disorders that Tom alluded to in the kind of doubling of the SAMHSA budget, which that's a drop in the ocean. We really need to have Medicaid and our larger health systems, our commercial health systems, pushing these types of things. And we need to move away from this idea that we need to take you away from your community for 30 days to get you over a substance use disorder. Really, if you have an opioid use disorder, and there was just a New England Journal of Medicine study that a good friend of mine, Madhukar Trivedi, was lead author on, showing that now we are seeing some of these same naltrexone being able to be useful for methamphetamine dependence. So we are getting better at being able to provide medical treatment, and we need to bring full equity and full parity of substance use disorder treatment into our medical and health systems. And then, like Susan was saying, get upstream from that, get out to where folks are who are homeless or folks in schools. Let's be proactive. So let's just kind of do more of those two things. And we'll be very thankful here in Texas and probably in other states as well.
Susan, I want to address a comment here from Trey Normoyle. He says, I'm a psychologist and behavioral health director working for an FQHC, and we're doing outreach to our migrant agricultural workers, and we have been fortunate enough to have mental health providers who are from this population. It helps to reduce fear and stigma, and that they're also working on it to increase telehealth options in very rural areas. So I'm wondering, where you sit at Dogwood as a philanthropic entity, how do you think about this cultural competency piece and helping to support the development of a workforce that can better reflect the members of its community? What are your thoughts there?
Yeah, that's very important. We know, especially right now in COVID, we have a lot of displaced workers and we have a lot of needs. So we are really looking at where are those opportunities to help get people some education and training, and especially people from the communities, whether it's a migrant farm worker camp or people within communities who know best what that community needs. Being able to develop those programs through our community colleges or our institutions of higher education, and really bringing people from the community to get that education to come back and serve their communities. I think that is a strategy which helps build the capacity and helps with retention of great people, to serve and really understand the needs.
From where you sit in California, and using some of the tools of the digital health space where you're involved, what observations and lessons can you share about this cultural competency piece working to deliver telehealth across a diversity of demographics? What are your thoughts?
Well, first of all, I'd say the need here is probably even greater than in other areas of medicine. We've just got to think through how to be able to provide particularly psychological interventions in a way that's meaningful. And in California, because it's a majority minority state, and we have a large proportion of the state that is not English speaking, or at least not speaking English as a primary language, just getting people who speak the same language is quite a challenge. The answer to this is not so much in training up the current workforce, but in expanding the workforce with peers who you can train up, who represent those populations. And we've seen this over and over again, that those peers are able to get engagement in a way that just hasn't happened from the more enterprise-driven healthcare system as we know it. The other piece of it is we've become more and more interested in the sort of tech peers, the people who are not only from the community, but can use technology as well to engage and to help people get online and to understand how to access tech solutions. There are an enormous number of them. Andy, I was thinking about this because the report came out this week that there was a $1.4 billion venture capital investment in the last year for behavioral health technology. $1.4 billion is about what NIMH spent last year for research, and only about 25% of that's going to new projects. So it's an enormous industry right now that's likely to have a very big effect. And in California, we think about that a lot. We've got a lot going on in terms of just the way Susan mentioned in North Carolina. In California, we're creating a new waiver system called CalAIM that will open up Medicaid, which we call Medi-Cal here, to pay for a whole range of services, including not only the nonprofits, but engaging the tech industry as well, to figure out how to move upstream, how to provide what we call whole person care. So it's not just driven by the crisis. It's not just trying to respond in the most expensive and inefficient way, the way the current system does.
So I got to just sort of gasp a little bit there, Tom, that venture capital investing about $1.4 billion, if I heard you right, last year, is about equal to the National Institutes of Mental Health and their investment. That's really something. I guess give me a sense of tech's hope, the tech's promise to help this. I mean, on the one hand, I think the telemedicine story and telehealth story is one of the great stories, positive stories, silver linings out of this pandemic. On the other hand, if anybody's talked to a tech person, particularly in Silicon Valley out of in venture capital, so often those folks are trying to solve problems that are not really at the point of patient care, and I sometimes grow cynical about some of the problems that they're trying to solve. So give us your sense about the hope and the promise of technology.
Yeah, DJ, I actually just 2 days ago, I published a piece in Stat as an op-ed on exactly that issue, that all that investment, that $1.4 billion is often going to places that aren't solving the problems that we have in the public health system. And there are a bunch of reasons for that, but there are some corrections. I think the important piece is not to think about technology in terms of what kinds of bells and whistles, software, hardware, shiny objects it can produce, but how it can improve care. And the key, we've been entirely focused with telehealth on, we can improve access. Access is actually not the answer. It's not the problem we need to fix. The real problem we need to fix is quality. And so the question is, how do you use technology to improve quality? It goes back to Andy's comment about with suicide, we're not measuring. So if you can think that telehealth, which right now is just taking what you were doing in a brick and mortar office and putting it onto a phone or putting it onto a website, if you can think about that as 1.0, telehealth 2.0 will start to measure everything that happens in that interaction, creating dashboards for both the patient and the provider, and allowing people to create what we would call a learning healthcare system in diabetes and hypertension and every other part of medicine. Just hasn't happened in behavioral health. That's where we need to go. And technology can help us with that.
So Andy, I want to ask this question that comes in from Brent Fisher, who's on the board, I believe, at the Alaska Mental Health Trust Authority. He says, HIPAA restrictions are a major issue with providing care via telemedicine. I think he would extend his view to in many cases, regulations being overly burdensome in a number of instances. But he says the relaxation of these restrictions during COVID-19 has greatly expanded access to care. What can be done to loosen these restrictions permanently? Wonder what your thoughts there are about whether some of the restrictions or some of the allowances, like parity for reimbursement, will continue, and whether audio only will be allowed. I know in Texas, some plans like Blue Cross Blue Shield have already eliminated parity. What are your thoughts?
Well, Blue Cross Blue Shield did on telehealth thing. They did do some retrenching on that on the mental health part last week. So I mean, I think people are trying to figure this out. What is the right piece? And I think what I'm hoping we do is we could just keep it like it is now and sort it out. Like it's clearly better, but we don't know exactly all the ways in which it's better. And, I got to tell you on HIPAA, one of the things that's better is y'all just quit being so persnickety about it. I mean, like the biggest barrier to HIPAA, and I'm pro HIPAA, like I don't want my healthcare information in the wrong hands. I certainly don't want my children's healthcare information in the wrong hands. But mental health providers in particular are wrong in how they deal with HIPAA. They think of HIPAA as I can't talk. That's not what HIPAA means. HIPAA means you have to protect certain information, but you better darn well talk to a parent whose son is suicidal. Figure it out. And, and I think we also have a whole industry trying to scare people with HIPAA that I get like 10 emails a week, like, how can HIPAA protected for you from HIPAA so it doesn't destroy your practice? I don't know anyone who's been sued over HIPAA. I knew a lot of people have been sued for negligent care who failed to coordinate around someone in crisis. So I think that a big thing of what we did is people just chilled out and actually just started delivering healthcare and quit being, overly worried about it. And so my encouragement is y'all as providers, worry less about HIPAA. HIPAA's a way to communicate. Don't share people's secrets, but give people the information they need to figure things out. That being said, there is a long list of stupid things that we don't have to do anymore that hopefully we'll be able to piece. And Tom and I just want to say that there's a resource. I don't know if we can put the link to it in the chat, but Tom and I were with 12 other organizations that put together a collection of policy objectives that fit into kind of 6 overall priorities to just try to maximize our gains in mental health. And the thing about them is they're all just very straightforward things to do. I mean, there are things like, for example, collaborative care. If we had universal access to mental health in primary care, which is paid for, our insurance pays for it. 15 states Medicaid's programs pay for it. Hopefully Texas will join them soon. We could cut the death rate from suicide up to 1/3. I mean, and it's just doing things we know how to do now. That's why the National Response Action Committee has put this together. The steering committee has put this as a priority. But, so treat HIPAA in the same way you would for any other illness. Just don't be overly worried about it. Comply, but don't be paranoid. And I think there's a list of things like that would make things dramatically better.
Hey, Andy, I'm so glad you mentioned this because we should put in a plug. It's in the 4 decades I've been in this field. This is the first time that all of the advocacy groups, the major guilds, have gotten together to speak with one voice. Pretty amazing. So NAMI and Mental Health America, the APAs, the National Council, all these groups got together. You and I were on the same huddle, as we called it. But 14 of these agencies and organizations have joined together for this unified vision. So I do think it's important, both for the new administration, but for the public more broadly, to know about that vision and what it says. If there's a way to distribute it, it's now public. And it doesn't hit every problem, but it goes after early intervention, crisis services, equity, issues around parity and standards, and how to fix the workforce. So it's pretty comprehensive, and I think it's in some places even a little radical.
We have now 200,000 people on our email list segregated into our different states. And so we will share this video, this event, and we will link to that report in the post so that people can see it. We're running low on time. I want to make sure that we can round out and people can take this and carry on with their day. I want to give each of you a chance at a final word with the question of what advice or what counsel would you give people who are on this listening in today, either live or when it's recorded? What advice or counsel would you give them about leading their organizations and navigating the next 12 months as we hopefully get through this pandemic? And so, Susan, let me ask you that first. Your counsel to the people who are listening in on this.
Yeah, I'll probably come back to where I started. Look for what we have done, the good things, and the hope in the way that we have changed fairly radically in a very short period of time, in a way that we probably didn't think we could if you had asked us right before this came. And so how can we keep what's good and kind of keep that momentum going? And so many of the things we're talking about are, especially around healthcare delivery, are around having these two systems. And so I really challenge us, instead of parity, how do we talk about taking care of the person? So I challenge us to keep thinking about whole person care, including all of those things upstream that influence health down the way.
Good stuff. Andy Keller, tell us your thoughts, advice, or counsel that you would share to folks interested in, who have to navigate their organizations over the next 12 months.
Just do what Susan said. But I would add on that, because that is it. I mean, we need to, people with brains have bodies, and that's what's killing us. Those of us with mental illness who aren't getting treatment. It's not, some of us are dying from what our brains are doing, but most of us are dying from premature heart disease, untreated pulmonary diseases, other infectious diseases, and disproportionately from COVID. So I think the thing I would ask people to do is be hopeful. We know what to do for most of these disorders, and let's just bring our mental health experts into the conversation. Let's bring them in and bring them into the healthcare delivery, and then even better, bring them into these social determinants so we can get ahead into our schools, into our education system, so we can get ahead and have a generation that has a very different future, where suicide rates are like the rest of the world's, and maybe even better, because we can do it better here.
Tom, last word. What counsel would you give?
I really like what both Andy and Susan have said. I would just echo that I think let's change the focus from healthcare, which is all about us, to health, which is really about the public, and giving people what they want, when they want it, where they want it, how they want it. And I just, again, would put in a plug that technology is one way to do that. Maybe not the 1,000 apps that are now available, but there are tools and solutions that are being developed that I think are pretty exciting. So I think it's time to start engaging some of those and making them answer the public health problem.
Tom Insel, physician, chair of the Steinberg Institute, former head of the National Institutes for Mental Health, and former mental health czar for California Governor Gavin Newsom. Thank you, sir. Andy Keller, PhD, CEO at Meadows Mental Health Policy Institute out of Texas, and Susan Mims, MD, Dr. Susan Mims, who is the interim CEO at Dogwood Health Trust out of North Carolina. Thank you guys for making time to be with us. And to the almost 1,000 of you who are registered to be here with us, I appreciate your time and glad we were able to get some of your questions integrated into this conversation. We will post this at our site and share it as broadly as we can. We'll continue to have these virtual conversations. We'll continue to have them in each specific state in which we operate, but we'll also make sure that we tee up some of these multi-state conversations as well. So thanks for your support of what we're doing here at State Reform. We'll talk to you again soon.
Thanks for joining us in this virtual conversation and for your support of our work at State of Reform.